Good morning, good afternoon. I've been asked to discuss a very important topic, that is advances in laboratory mycology. What is the challenge or need in case of the fungal diagnostics? I would say early diagnosis, that is critical. But the impediment for diagnosis is that conventional techniques are less sensitive, long turnaround time. And most important thing is that to identify the fungus phenotypically, we need expert mycologists, which are diminishing in number throughout the world. And if you see in case of resource-limited countries, wherever the progress that is not reaching those areas, that is very important, though they have large number of opportunistic fungal infection. You know, the contrasting need is presented by increasing diversity of fungi, which is causing human infection. And recent challenges, especially the unprecedented fungal outbreak, COVID-associated mucormycosis, Candida auris outbreak going on for last almost a decade, Aspergillosis, these are very important challenges where we need quick diagnosis. Now, the traditional approach comprises of direct microscopy, histopathology, culture, and serology, whereas the advancement which is coming, that is in the field of molecular diagnostic, antigen detection, and innovative new technologies. I'm taking very important one example. This is from MD Anderson in the hematology malignancy patients. You see, in the last century, they used to have 84% of their invasive fungal disease diagnosed post-mortem. But in 2004 to 2008, they found that 49%, it had come down from 84 to 49%, which are diagnosed post-mortem. So this improvement had come because of preemptive approach or introduction of the molecular test in diagnosis of Aspergillosis. But the question is, can we improve further so that we can identify this 49% antemortem? So here, if we look into these two areas, one is the antigen detection, another is the area of molecular identification or molecular detection. First, in antigen detection, I would say we have a very good procedure available for cryptococcosis. I would say the cryptococcal antigen detection is the best test for antigen detection in clinical microbiology. Now, following that, we have new test came, that is the galactomannan and beta-diglucan. Possibly we can do the histoplasma antigen, but the revolution which is coming, that is through the lateral flow assay. So, in case of antigen detection, advantages are antigen which can be shed from a local site to the body fluid, so you can avoid invasive sampling, you can collect the blood or urine for detection of antigen. Second important, as I mentioned, lateral flow is making the revolution, that is inexpensive, rapid, and even the personnel with limited training can do this test. And if you can select good antibody which have broad range of fungus detection capability with limited specificity might be, but it all depends on clinical need. Whereas in case of disadvantage, I would say that we need surrogate marker for infection, like in case of cryptococcal antigen. And there is a problem in case of antigen, especially in non-sterile sample, to differentiate between colonization versus infection. Third most important thing is that, like in case of DNA, we cannot amplify the protein, and that way it is not possible like PCR for improving sensitivity. Whereas in molecular tests, our attention is mainly to those who had the common infections, Candida, Aspergillus, and Mucor. Possibly we can use this pan-fungal PCR and multiplex PCR. Advantage, it's rapid, high sensitive and specific. It can detect broad range if you use pan-fungal primer. It has got a multiplex capacity, and you can even detect antifungal resistance specific gene, which have been found special in case of azole resistance Aspergillus. But disadvantages are you need specialized equipment, specialized staff. It's an expensive, but most importantly, two important factors. because this is being present, this fungal DNA is being present throughout our environment, there is a very high possibility of false positivity, and we need standardization. So in case of the DNA-based method, we generally target the ribosomal area because it is multi-copy. It has got both conserved and variable region. Other than this ribosomal DNA target, several other targets have been made or targeted like beta-tubulin, calmodulin, actin. I'm not going into those details. Let's go to the main issue. And here, if I now go with the invasive candidiasis, aspergillosis, and mucomicosis, first coming to invasive candidiasis, I know it's a busy slide, but what I like to emphasize is that till now, our gold standard in diagnosis of invasive candidiasis is the blood culture. You know, blood culture, if you can do a high volume blood culture, that can improve the sensitivity. But even then, it is having the slow means its detection time 2 to 3 days. You cannot wait by that time. So people are concentrating more on the non-culture based diagnosis. You can have the beta-D-glucan test or Menon antigen, anti-Menon antibody detection, or going for PCR. But even by these present-day diagnoses, we are not able to exceed 50 to 60% antemortem diagnosis. So in 2017, we made this provocative statement in emerging infectious disease. We said delivering on antimicrobial resistance agenda will not be possible without improving fungal diagnostic capability. Because in a sepsis, whether it is a bacterial sepsis or a fungal sepsis, is a problem. So inaccurate diagnosis of fungal sepsis results in inappropriate use of antibacterial and antifungal. So antimicrobial stewardship program will go in toss. Here, there is problem is even with inappropriate use of antibiotics of antifungals, you develop resistance. But the present day biomarkers where we are trying to go to the point of care test. So can we do better? I would say this is one technique, that is the T2 magnetic resonance nanoparticle based detection, which helps in case of the identification or diagnosis of the bloodstream infection very early. Look at this, turnaround time 106 hours coming down to below 4 hours. So this is a very good procedure, can help in quicker identification or diagnosis. But I have got 3 caveats for it. First caveat is, it is detecting only these 5 Candia species. But when we had done many of this study across this developing country and Asia, what we found that nearly 30 to 31 species of Candida produce bloodstream infection. So we'll miss large number of them. Second caveat is that this particular test cannot replace conventional procedure because it cannot do the antifungal susceptibility testing. And third thing is that it is very expensive and still not available in Asian market. But where we have significant improvement, that is in case of identification by this multi-top. Whether it is yeast or mycelial fungi like bacteria, it can identify within few minutes. And possibly in near future, we can also perform susceptibility testing. Even in outbreak investigation, this multi-top is very useful. So coming to the Candia Biomarker, as I've already mentioned, these are the biomarker tests available. Main interest goes with the beta-D-glucan because though in Europe we have seen people are using Menon antigen or anti-Menon antibody detection, but this particular test helps mainly when the positive agent is Candia albicans. In others, the sensitivity is low. But in case of our Asian countries, we have found more than 80% cases are non-albicans Candida. So possibly we can concentrate more on the beta-D-glucan test. And this beta-D-glucan test is not Candia specific. It's a pan-fungal marker. Except in case of Mucor and Crypto, it can detect all. But if you look into the comparison of the presence of this beta-D-glucan, it is much higher in case of Candida, and then it is pneumocystis. So this beta-D-glucan, when it had been evaluated in one of the centers in case of India, what we found that if you have started empiric therapy And if beta-D-glucan comes below 80 picogram, you can stop the therapy. And possibly if you have got more than 150 picogram, it can diagnose invasive candidiasis. Even in case of the different international group, they have all said the same thing. This test can be used for stopping empiric therapy. This beta-D-glucan can also be used in BL and CSF, but it is still not standardized. Now, how this beta-D-glucan test is being done? There are now several kits available, but this is the most commonly used kit, that is the Fungitel kit, because it is FDA approved. And this particular kit, you see, it is doing batch testing. So if we have to use really optimally, then you need 21 patients. In case of the small hospital, you may not have on the same day 21 patients requiring this beta-D-glucan test. So what you will do? If you delay, it increases the turnaround time. But now this is a new test from the same company is coming up. This particular test can do a single patient. And you see the turnaround time has also significantly improved. It can be done within 1 hour. We like to evaluate in Asian countries this particular test. What about molecular diagnosis of invasive candidiasis? In case of the blood culture directly, you can use several kits are there, or you can extract the DNA and do the similarly defined kits are available. But I would say still the molecular methods for Candia diagnosis are limited in certain specialized centers only. The commercial tests need to be developed for broader application, further validation, and reduced costs. I would say here next generation sequencing is going to be very important in future, because here you can do the direct detection of microbe from the specimen. You can also study the microbiome. You can also look into the antifungal resistant mechanism. So all these factors can be done in future with this next-gen sequencing. And if I have to think about molecular diagnosis, one area where it would be very important if we can identify Candida auris in any of the patient's sample quickly. Because if you have to stop Candida auris in your hospital, you have to identify the patient who is colonizing with Candida auris. So how quickly we can identify? Generally, people say you can use the chromager, which can do quickly, but chromager can identify, even it would take 24 to 48 hours. So this is a technique which is coming up. I would say this particular test need to be evaluated in more number of laboratories, where it is claimed that within 1 to 1.5 hours, you can identify whether Candida auris is there or not. That would be very important if we have to really look into the patients who are coming into your ICU, whether they are colonized or not. Now coming to the Aspergillosis. Any molecular diagnosis in fungal infection, contrary to the virus and bacteria, has the problem is fungal DNA presence in the tissue is small enough. So if we have to use sensitive platform to improve the sensitivity of detection, the contamination issue comes in a very big way. So this is the Fungal Pcr Initiative under ISHAM, which was earlier named as European PCR Initiative. They had done a significant work in case of molecular diagnosis of Aspergillosis. It can do the PCR amplification method, which can be comparable. DNA extraction rate limiting, which they have found. They said that you have to take a large volume of the blood and elution volume should be very less, so that it can really concentrate the DNA. They have standardized the method in whole blood, serum, plasma, even BL sample. Analytical specificity had been identified. Possibly we can use the commercial PCR very soon. And if you look into this systemic review or meta-analysis, especially the Concurrent review says that if we have 2 or more 2 positive, then the specificity has got very good. But then sensitivity is not so good, 60%. But in case of the BL PCR, possibly it has got better sensitivity and as well as specificity. Another important thing in case of molecular diagnosis is that, contrary to the galactomannan, if the patient is on anti-mold prophylaxis, then galactomannan usually gives false negative report. But here, it doesn't affect so much in case of PCR. So it does not affect the sensitivity, though specificity could be affected. So with this development of Aspergillosis PCR, now URT-MSD definition for invasive fungal disease that had been proved or taken into the probable or possible group of fungal disease, especially in probable group. What it had been mentioned in case of Aspergillosis PCR that any of the following should be there: plasma, serum, or whole blood, at least 2 or more consecutive PCR tests should be positive. Similarly, in case of BL fluid, 2 or more duplicate PCR should be positive, or at least 1 PCR test in plasma, serum, whole blood, and 1 PCR test in BL fluid should be positive. So these are the commercial kits available for Aspergillus, have given the sensitivity and specificity of those tests, but I would say these tests require further validation because of their valuable performance. DNA extraction still is a rate limiting factor. We need Aspergillus specific DNA extraction kit. Mostly we are using eukaryotic extraction kit, but possibly if it is Aspergillus or it is fungal specific extraction kit, that would be good. Requires further standardization of this commercial system, and performance should be comparable to the Aspergillus antigen. Friends, here I have got a lot of interest nowadays. That is the point of care test. In Aspergillus lateral flow, there are 2 kits are now available. One from IMI, another from the well. Both are CE market. And you see here in IMI, it is detecting the galactomannan. Or possibly there is some undisclosed antigen which are there detected. Whereas here, it is the extracellular protein secreted from Aspergillus hypal-tip. It has been detected by monoclonal antibody. Both of these tests are comparable. You see small volume required, more or less within 10 to 15 minutes or 30 minutes, you can give the report. There are some amount of cross-reaction with some of the mycelial fungus. Especially this, using the cube reader, you can improve both the sensitivity and specificity. This has been evaluated in case of bronchoalveolar lavage fluid sample from hematology patient, and this gives a good sensitivity and specificity. When it had been compared with the galactomannan, you see this particular lateral flow assay is good comparable test. There is no problem at all. But what kit you should use, whether the LFA or LFD? This is one study available head-to-head in case of hematology patient, which shows that lateral flow has better sensitivity and specificity compared to the LFD. And when this meta-analysis, I looked into it, it shows whether it is in hematologic malignancy or even patients in ICU, the sensitivity and specificity is better with lateral flow assay from IMI rather than from the OLM. But friends, I would say I'm not that much sure that whether we should only use IMI or we should not use the OLM product, because I need more evaluation. These are very few results which are there. Possibly multi-center study, which at present in India we are doing, can give you an answer whether this lateral flow assay or LFD or both these should be used in case of detection. Now there is another interesting development is the urine antigen detection. This urine antigen detection, you see that this is a procedure from Kiranmar's lab that had in John Hopkins Kiranmar's lab that had given a very good result in case of this, that is the galactofluorine specific monoclonal antibody, which can diagnose pulmonary aspergillosis. And this is in the urine. This is now developed by a kit attempting to develop a lateral flow assay, and it uses 120 to 150 microliter urine and giving good sensitivity and specificity. But further, they have proceeded to this particular company and they have developed a sandwich ELISA with 2 monoclonal antibodies. These are same, this galactofluoronoside specific specificity is there. They are possibly detecting or recognizing small molecular glycan as well. tested in 920 specimens from 310 hematologic malignancy and controlled. Sensitivity and specificity showed very good result. Some amount of cross-reaction with histo and fusarium. And this test also detects early. So there is a potential for screening. I'm very much interested when this kit will be available in Asian market. Histoplasma. Histoplasma antigen people were not using because of the cost, though the kits are very good. But now that they are coming with lateral flow assay, even the Miravista, they are coming with the same kit or lateral flow assay. Even this OLED-DX, they are also coming with this type of lateral flow assay. Both of them had shown good sensitivity and specificity, but we need more evaluation. Coming to the Mucor. Mucor has no biomarker. So Mucor PCR would have been very important in that use. Though there are some in-house study are available, but I was looking for some commercial kits because that would be more standardized. And when in all this particular COVID-associated mucormycosis outbreak happened, we tried to look into this mucogenius. But we found that this sensitivity is comparable to the conventional. It's not very high, and it's not also detecting very early. Almost when the culture becoming positive or the microscopy is positive, then only it is detected. So it requires more evaluation or standardization. Lastly, I would say that most of our interest coming into this area, that is the cell-free DNA. Whether it is in bacteria, parasitic, even in case of the fungus, even in virus, nowadays people are looking for cell-free DNA that can help, like in case of cancer, for diagnosis. You know, the cell-free DNA comes from the blood cell. If it is present inside the neutrophil or anywhere, it is coming in the plasma. So you can use the plasma for diagnosis. There are 2 studies available. Both are still online in clinical infectious disease. In one study, they have used real-time PCR for multiplication. Another used the metagenomic approach. So in this real-time PCR, they have used a bioinformatics pipeline looking into the 12 medically important fungus, genera, and species. And when they have evaluated in 226 patients with invasive fungal infection or control, what they found, this particular test has a sensitivity of 70%, but specificity is good. But where it really impressed me that it has got positive impact in clinical management in 42.6% cases. You see, there is the problem, something is there in case of Aspergillosis. Otherwise, the sensitivity would have been good because in Mucor cases, they have shown very good sensitivity. So possibly we need some improvement in case of this Aspergillosis cell-free DNA detection. Going to the next one, that is the metagenomic approach which have been tried. And in this metagenomic approach, they have used 114 post the stem cell transplant pneumonia patient who had their plasma had been stored within 14 days of the diagnosis they have used. And what they found, their sensitivity is around 51% by metagenomic approach. But when the samples which have been obtained 3 days within the diagnosis, that's the sensitivity increased to 61%. Combining with the galactomannan, the sensitivity further improved. But you see again, the same as it had been shown in real-time PCR, that Aspergillus, still the sensitivity is not good. It is good for non-Aspergillus DNA. This is the further development which is coming in case of cell-free DNA. Here, the whole genome bisulfite sequencing is being done for this cell-free DNA. Along with that, there is also cytosine methylation, which is measured. Now, this cytosine methylation decides what tissue is being damaged. You know, not only detecting DNA inside the blood or urine would be important. You need to know whether what tissue is getting damaged by this particular infection. So combining these two, if this procedure comes, that would be very good, which is being in the process of development. So friends, what I need, that ideal next generation fungal diagnostics that would detect early. It should have strong negative predictive value. good turnaround time, it should be low cost, non-invasive samples can be used, and you can see that even limited trained people can also do it with uncomplicated interpretation. So the pros and cons of all these tests, I would say PCR is rapid, sensitive, but it requires purified template. Contamination is a major issue in case of PCR. Sequencing for identification of the species, yes, this is very important, high specificity, but it is having got a high capital cost and requires technical expertise for data interpretation. Whole genome coming in a very big way, that is high specificity. It can have the epidemiology or drug resistance determination. But again, this is also having high capital cost, additional supportive equipment is required, and technical expertise is required. Hybridization, especially multiplex platform, is very important because it can detect, both identify as well as can look into the drug resistance gene. But again, it is having got high complexity, variable capital cost, and needs technical expertise. But where I am very much impressed, that is in case of mass spectrometry, because you can identify any fungus within results within minutes. Easy to moderate sample preparation. But here only thing is that high capital cost. But I would say consumable cost is very minimal. That's very important. But here the most interest going nowadays to the lateral flow assay because it is rapid, point of care, inexpensive, but it still needs standardization and cross-search. So summarizing, what I tried to tell you is that we need rapid diagnostic tests with good performance, especially in patients with hematologic malignancy. You see here, isolation identification where you can do it with T2 or MALDI. In case of the galactomannan or other antigens, I would say galactomannan lateral flow is a very important one. In case of beta-D-glucan, the single test format which is coming up is very important, and we need standardization in CSF and BL sample. In case of PCR, both Aspergillosis and Mucomicosis PCR would be very important. And metagenomic sequencing, especially for cell-free DNA, that would be very important because it is the modern days development which is coming. So more commercial assays are becoming available in case of fungal diagnostic. But friends, I would say there is still no replacement of histopathology and culture that would remain as an essential investigation. At the end, I like to invite you for this World Congress, which will be from our International Society during 20th to 24th September 2022. That will be in India. I invite all of you to attend this conference. Thank you for your kind attention.
So we have Professor Chakrabarti joining us for some Q&A. So the first question that we have is from the audience. Is there an lateral flow assay test that's available for beta-D-glucan detection currently?
We have no lateral flow yet, but it is in case of galactomannan we have. But possibly very soon it will be interesting that if we can have lateral flow assay also for beta-D-glucan.
Okay, but it sounds like not available currently, but hopefully in the near future. Thanks. May I also ask that you mentioned in the talk that as part of the diagnostic criteria for invasive aspergillosis, so this is with regards to the PCR, you mentioned that it requires at least 2 or more positive PCRs. Just wanted to clarify if you meant that there was 2 separate sample collections, or if it was a repeated, or it's like sort of a reproducible test from the same sample.
Usually the samples is consecutive day sample, or if it is alternate day sample, is only one PCR without any culture or direct microscopy, just to diagnose with the PCR or any biomarker test with a single test. It's a real problem because there is always a chance of false positivity. So if you have got 2 consecutive day samples which becomes positive, it gives more confidence in case of diagnosis of invasive aspergillosis.
Do you take the same approach for other diagnostic testing modalities as well? Because as you know, sometimes we order multiple tests, including galactomannan cultures at the same time, and there may be discrepant results between them as well.
Usually, we desire to have, say, 2 samples. Miss next day, if it comes positive again, or that would also help that if there is any rise in, say, suppose in case of the index, galactomannan index is going up, or in case of the beta-glucan going up, that would also give more confidence in diagnosis.
Okay, thank you. And we have one more question from the audience regarding the Aspergillus PCR. Are the sensitivity and specificity calculations measured against proven invasive or probable aspergillosis, or just the presence of aspergillosis, whether colonization or otherwise?
Mostly all these sensitivity and specificity measured, including proven and probable cases. Possible cases are usually excluded. Most of the studies are taken proven and probable together.
Thank you. And just one more question from the audience with regards to fungal sequencing between the ITS and D1, D2 regions, which would be a better choice as a target?
In case of the East, it is the ITS2 which is very useful. But in case of even in case of East, we can use the D1, D2 region. But in case of the mycelial fungi, we have to go look for 18S area or sometimes in 28S area. So like suppose mucorales, we usually look into the 28S area. So all these, you have to look into where it is more useful. Usually for barcoding, people tried with the ITS2 in case of the diagnosis of the fungi, but there are certain problems always been there, that there are either it is not separating all the species, then you have to go for further sequencing of the other region. Otherwise, it is people prefer to have the at least ITS2 and D1, D2 region.
Okay, thank you very much, Professor Chakrabarti. So I think that was the last question that we've had from the audience. Thank you again for joining us for the talk and the Q&A session, Professor.
Thank you very much.